Okay. Okay. Hi, everyone. I think that's pretty much everyone. So we'll get started in a second. I'm Anetta. I'm from the Bridge Lab team. And then with us, we have Dr. Patel-Sanchez, who's going to be handling the majority of the questions in the presentation. So let's see if this works. Um, okay. Oh, no. 1 second. Okay. So do you guys see everything? Okay. Awesome. So welcome to the GI webinar. We're going to be covering GI challenges faced by a lot of patients who have Noonan syndrome. There's a lot of common issues. We've looked at your questions, we've taken some of them, and we're going to address them all at the very end. Um, and so the event will be recorded. It's currently already being recorded, and we'll send out the recording afterwards to everyone. If you ever want to take a look back, and then it's going to run until 3:45. We're going to try and wrap up by then. And we loved getting all your questions. And if you have questions during the presentation, feel free to send them in the chat, and I'll slowly get the questions to Dr. Patel-Sanchez, who will address them at the very end. But yeah, feel free to send in questions at any point during the event itself. And so kind of a quick overview for today. We're going to introduce Dr. Patel-Sanchez, and then she's going to dive into a quick presentation on a lot of common symptoms and a lot of common treatments for a lot of those issues. And then we'll dive into the Q&A, which will be the majority of the presentation today. Um, so our lovely speaker is Dr. Namrata Patel-Sanchez. She's currently a pediatric gastroenterologist at UCSF at the Oakland Extension. And she's also an assistant professor of pediatrics at UCSF School of Medicine. And I'll let her hand over from here and introduce herself further.
Hi, everyone. Yes, I'm Dr. Namrata Patel-Sanchez. As she mentioned, I work just around the Bay over here in Oakland at Benioff Children's Hospital associated with UCSF. And mostly my area of expertise is in nutrition. And so I take care of kids with feeding disorders as well as, so not eating disorders, but feeding disorders, as well as patients with intestinal failure. And then sort of a little bit on the other spectrum of things are patients with fatty liver disease that may have different type of nutritional disorder. Great. Next slide. So as I'm sure many of you know, that Noonan syndrome is a clinical diagnosis characterized by short status, webbing in the neck, typical facial dysmorphisms, and a wide spectrum of congenital heart defects. It can be associated with genetic mutations, and sometimes the symptoms of difficulty with feeding or short stature leads to the diagnosis. Next slide. So these are the 4 common gastroenterology issues that we see in this patient population: feeding difficulties, poor appetite, reflux disease, and constipation. And we will talk about each of those today. So the first one is feeding difficulties. So there actually is a few studies that reports that feeding problems in Noonan syndrome develop most often in infancy and do decrease with age. One study found that of the patients that they looked at, a third of the patients required a feeding tube, a third had dietary restrictions, and a third had no feeding problems in the first 6 years of life. Majority of the patients do develop feeding problems at ages less than 1. But those that develop the feeding problems later on, so late onset feeding difficulties, may be due to sensory processing issues that can be associated with autism, delayed gastric emptying, reflux disease, or a non-GI disease, such as cardiac issues or infections. What is the treatment for feeding difficulties? So it's definitely twofold. We often recommend feeding therapy for our patients. They can work with a therapist specialized in skills that you can learn as as the people taking care of the patient with Noonan syndrome, but also that the patient themselves can learn how to eat in a way that they enjoy. We do recommend that, of course, we defer to the feeding therapists themselves about how frequent therapy should be. Their feeding therapy can be difficult to access as there are not that many feeding therapists available. This is due to this special certification that feeding therapists must obtain. However, um, you know, there are actually now a lot of virtual options that started, I think got more popular during the pandemic. And, you can ask your GI specialist or maybe a therapist that you already work with for possibly something else if they know of any of these other options. And then another option, patients with feeding difficulties may be an enteral tube, although, it may depend on swallow study that the patient gets prior to making the decision if a patient needs an enteral tube or not. And so I listed here what are the different enteral tubes. And the first option, as you can see, is an NG, which otherwise stands for nasogastric tube. And this is the tube, as some of you may have seen, goes in the nose, hangs out a little bit outside, and then drops down into the stomach. The pro is that it's easy to remove, but also that can be the con, right? Because the kids might be always pulling them out, and then they have to be replaced, and that may require multiple visits either to an office or urgent care or emergency room. So there's that. There's another con that's rare and infrequent but can happen is ulceration in the back of the nose if the NG tube is in there for too long, which is why we often recommend a G tube. G tube is one that stays in place. It cannot be easily removed, especially by the patient, but it can be easily replaced by the caregivers at home. And so that's always really nice that it can be replaced at home. The cons are that it can require surgery to place, or definitely sometimes can be done by GI providers as a procedure. And so the first couple days after placement, there can be pain associated, but oftentimes patients recover within a few days from the initial placement. And other cons can be that the area around the tube itself can have issues such as granulation tissue, which is the most common where there's extra skin. So the tube placement itself doesn't come with sometimes complications, but in many of our patients, it seems worth it because it's an easy way for families to give nutrition. There is sometimes some patients that have issues with motility or delayed gastric emptying or gastroparesis, and sometimes the feeding tube that is directed into the stomach does not help or does not work. And for those patients, we often recommend a gastrojejunal tube, which goes in the same location as the G tube goes, but the inside portion is longer and goes past the muscle of the stomach and goes straight into the small intestine. And this is really nice for patients with poor motility of their stomach or have severe reflux disease. The cons are that it can be difficult to replace. Often it requires interventional radiology, which is only available at many special centers. It cannot be replaced at home. And then also it can flip out of the small intestine into the stomach. Sometimes some parents feel like some patients don't respond poorly and have pain with the tube. So, you know, it can be really great. And then, like everything, it has pros and cons. Lastly, there is a procedure where we place a tube that's not in the stomach, beyond the stomach, and straight into the jejunum or the small intestine and completely bypasses the stomach. However, we strongly generally recommend against this tube because it heals very poorly and there's a lot of leakage, and oftentimes families have a lot of struggle with the area of the tube, much, much more than the gastrostomy tubes or the tubes that go into the stomach. So unless it's dire, we really avoid a small intestinal tube placement. Okay, next slide. Poor appetite is another common GI disease, disease or disorder that we see in patients with Noonan syndrome. There's often an unclear etiology. We think that patients may be sensitive to certain textures, tastes, colors, so there may be some sensory oral aversion. It could also be that eating may be very tiring with their associated heart disease, we find. So aside from feeding therapy, next slide. In these patients, we recommend, alongside feeding therapy in these patients, we recommend sometimes an appetite stimulant and formula. And these are the formulas that we also recommend go into the tube and all the tubes that we had talked about previously. So which appetite stimulant? There's not that many used in young kids, and often in patients with Noonan syndrome, the GI issues are present when they're very young. So the most common medication we use is cyproheptadine. The other appetite stimulants on the market generally are for much older kids. And these medications, the tricyclic antidepressants or amitriptyline, nortriptyline, or doxepin, we don't recommend in patients with heart disease cause arrhythmias. So we generally, cyproheptadine is the medication of choice. So if that doesn't necessarily work, it may be that might not be another medication solution available. We do have many formulas though, and so don't want you to get disheartened if if the child that you take care of doesn't like one formula. I've only listed half of them here, but I've listed all the brands. And so there's, Abbott has Pediasure, Nestle has Boost Kids and Nutrient Junior, and Kate Farms makes their own. And so there are different companies, different formulas in those companies. They come as regular. So those are ones that kind of taste like milkshakes. And then there's blended that taste more like smoothies. There's peptide, which is when the regular formula milkshake type or the blended ones are processed. And so in a way that the proteins are smaller and therefore easier to digest down at the molecular level. And a lot of our patients with reflux disease can benefit from that. And then some patients need the formula to be all the way down to the elemental or very, very broken down. And that is our most hypoallergenic formula. It's very rare that we have patients that need such a broken down formula, but it happens. And, it may take some time to get to realizing that that's what that patient needs. Slide. A third complication that is often described is reflux disease. It can be due to issues with body habitus, motility, anatomy, or diet. We often always recommend reflux precautions. So avoiding eating at least 2 hours before bed, try to stay upright after feeding, avoid overeating, and avoid trigger foods such as fatty or spicy. And oftentimes we also start patients on medications. It can be that different formulas are tried first, such as we had discussed previously, and if that does not respond well, then we may try medications. So these are the two classes of medications that we use most commonly for reflux disease, and that's histamine 2 receptor antagonists and proton pump inhibitors. So some brands that you may have heard of is Pepcid, which is a H2RA, or you may have heard of Prevacid or Protonix, and those are PPIs. So they are two different classes of medications that we use. And the last very common GI disorder seen in patients on the Noonan syndrome spectrum is constipation. Very often it's our patients with constipation that we recommend a higher fiber diet. And so that includes both soluble and insoluble, soluble being in vegetables and fruits, insoluble being whole grains. And so we try to do a diet history with all of our patients and see in what ways we can get more fiber into their diet. We do recommend water. We have plenty of patients that respond to water. Not all, but many do. I put this fun Bristol chart here, which is a cartoon depiction of different calibers of stools. And we like to aim for type 4, but it can't. Type 3 and type 5 are at the spectrum. If it gets to type 2, type 1, that's when we really think of constipation. And of course, we'll talk to you about how frequent it's passing and how it feels for the patient to pass if it's difficult or not. There are many different types of medications, but there are mainly two categories. And there's the stool softeners, which we call the mush agents, and then there's the medicines that promote motility in the colon. Those are the push medications. And so I listed them here as options of stool softeners. The Miralax, lactulose, and magnesium hydroxide are osmotic, meaning they pull water in. Colase works on different receptors to help soften the stools. Senna and bisacodyl are two different medications. Senna comes as a liquid, so it's used more often, where bisacodyl comes as a tablet or suppository. And then, of course, enemas help both soften the poop at the bottom, but also help move things along. These might be ways that people treat constipation. Okay, so I just wanted to review some of the main GI issues and talk about them in somewhat broad strokes, but I'm happy to take questions at this time.
Yeah, we're going to really quickly dive into a lot of the questions we received from the form earlier. And then feel free to, meanwhile, as some of you have already done, put your questions in the chat, and we'll get to those as soon as we get through the written questions. Yeah, okay. So to start, what are some first recommendations for a child with Noonan when referred to due to low weight gain?
So oftentimes, of course, it's individual and unique to every patient. So based on the history, I will try to determine which of those four categories I feel like is the most concerning and suspicious for why the child will have issues with weight gain. Almost universally, I'd probably recommend a formula to help supplement the nutrition so more calories can be given to the patient. But upon further assessment, we'll just make sure that there's nothing to do with their heart disease. We'll make sure there's not something to do with how they're eating foods or tasting foods or swallowing foods. And so decide if they need feeding therapy, if they need an appetite stimulant. But the first recommendation would be to try to get some more calories in so we can fix the weight gain as soon as possible.
Yeah. And then for a longer question, what are the effects of malrotation on the intestines and failure to thrive? And does malrotation prevent the intestines from getting all the nutrients it needs? Additionally, do you know if malrotation is painful when eating or digesting food? And does this cause a food aversion in children?
Great question. So malrotation is, as it says, a twisting of the intestines. So oftentimes the stomach empties and then the intestines rotate and move around. And this is when they don't move into the right direction and get stuck. And so there can be a twisting, and that can be painful if there is a twisting that gets locked and doesn't release. It usually leads to vomiting or pain. And this is likely at the same time as there is digestion because liquid is moving through. It if there is vomiting or severe reflux, that might cause food aversion, though. And of course, anytime there's pain with eating, that can also cause food aversion. So it's possible. Generally, majority of malrotation is unnoticed, and a lot of patients grow with it and maybe and then develop symptoms possibly later. It's either those or the group is that they found malnutrition very, very early in life because they're not able to eat foods early in life and vomit often things, and it's found. It does not prevent the intestines from getting all the nutrients because it does not affect the intestine at the sub or the mucosal level. So the intestines just to be able to absorb all nutrients, and therefore it shouldn't necessarily cause failure to thrive in that regard due to malabsorption. It may just cause failure to thrive due to lots of vomiting.
Yeah, thank you. And then are there any developmental signs that a child is ready to be weaned off the tube? And on average, what age might children on feeding tubes be able to wean off of them?
These are great questions. Oftentimes, we rely on the expertise of our feeding therapists to see their signs. And generally, the signs are that patients are bringing things to their mouth, they're starting to be interested in foods or drinking, and they want to pursue that. And if they're able to start and it's safe to start, then we we allow the patients to go ahead and start eating and drinking and slowly change textures and see how well they do with different types of textures and can grow. And based on their growth and how much they're taking in, that's when we start weaning the tube. It's all about calories in and growth to see when a patient is ready for tube weaning. And of course, also interest in eating and drinking so that they can be ready to take all the calories that they need to grow. The age really depends. It's found in Noonan syndrome. Lots of literature shows that um, much of the feeding difficulties improve after 1 years old. We see that it can take sometimes up to age 2 or 3. Sometimes it takes until they get to school and they see other kids eat a lot and they are motivated by seeing peers eat a certain way. So it's very individual, but generally we see improvement in the 1 to 3 year old range.
Yeah. Wow. And then for another question, someone said, my son just started Paristine. Have you heard of successes with this?
Yeah, I saw this question and I wanted to talk about there's two things I wonder if it's Paristine is referring to the Paristine pump. Um, we have had patients have success with that. That's where it's a catheter inserted from below with a balloon and allows for enemas. And it doesn't put pressure on the patient to have to hold in the enema. Of course, it does require a family to be comfortable with placing a catheter inside. Um, and we've had patients do really well and have success with that. And eventually, with enough enemas, the stretch of the colon that happens from chronic constipation can improve and decrease. And so it does do well for the patients that use it frequently enough and for long enough, and that their muscles, colonic muscles, are able to tighten and get to a place where they can have more regular bowel movements on their own.
Mhm.
If
Yeah.
it's
Wow.
there's a medication of periactin, and I think we already covered periactin if that was um, what was meant to be said instead of Peristeen. So
Yeah. And thank you for the information. And then another said, my daughter just has general discomfort in her belly off and on, depending on the day. She also experiences nausea and vomiting with no other symptoms about once a month. Any suggestions?
this is a challenging question in that it could be many things. We definitely would want to think about reflux disease. Those can definitely cause symptoms of discomfort, nausea, and vomiting. It can be poor gastric emptying, as those can lead to all of these symptoms as well. It can be just certain foods that may be triggering. And so it would be worth doing a food diary and seeing, what she had had in the 24 hours before the symptoms and seeing if anything can be pinpointed. A common theme on the days that she has these symptoms and the foods that she's eaten. So I always recommend a food diary. And the food diary is it's not as important to write down how much, but
Mhm.
which foods. And so you can find the pattern. It's not about necessarily counting a food.
Yeah, that's a really interesting observation. And then how is excessive phlegm related to vomiting, and how does one manage excessive phlegm, as well as is chronic vomiting common in Noonan syndrome as a whole?
Excessive phlegm can be challenging to manage, absolutely. There are some medications that we use to help thicken the phlegm. And so that can sometimes lead to less phlegm, although in some patients, thickened phlegm is harder to get out. So it's trialing some. There is sometimes a scopolamine patch that can sometimes dry up the drool or phlegm. But again, that might be It causes other things to dry, it can lead to constipation. So there are a few therapies that are used to help with phlegm. Oftentimes we manage that alongside lung, the pulmonologist, lung doctors, or ENT, the ear, nose, and throat specialists. And we work together to see if we can decrease the amount of phlegm to
Mhm.
understand, because it would be important to understand why the patient has excessive phlegm. It can have phlegm from vomiting if you're retching so much, but generally it's often related to maybe something in the nose or something in the throat, can be to the allergies. It can be related to swallow dysfunction. There are many causes, and so one would need evaluation prior to therapy to
Gotcha.
see the cause. And then chronic vomiting, I don't see it commonly, more that there are feeding issues and oral aversion rather than the vomiting itself. It is found that reflux disease and delayed gastric emptying are seen in Noonan syndrome. And so that can lead to chronic vomiting. Um, so those might be the causes. And it may be worth evaluation for delayed gastric emptying or reflux disease if you're seeing chronic.
Mhm. Um, and then next one. We've pretty much finished a lot of the questions from the form, and now we'll start pulling questions from the chat. I'm gonna cut the recording here, just because some of these questions in the chat sometimes are more personal, or share personal information. So 1 second. Gonna cut the recording. Okay.